So for our agenda, oh, there we go. Um, so for those who may not be familiar with our organization, the VESS was started as a national forum for students interested in vascular surgery to participate in, specifically focusing on those who don't have any home VSIG program at their institution so that they can receive some continued vascular exposure and mentorship. Our specialized series specifically aims to reach those who are in their M3 and M4 years who are considering to specialize in vascular surgery. And so tonight's event is actually sponsored by Specialized Subgroup. However, it's going to kind of be catered towards M1 to M4, just because this is more niche demographic DO applying to vascular surgery. So for our agenda, we have starting off with some DO match statistics. Then we're going to move on to introducing our panelists. Afterwards, we're going to begin the Q&A and finally just conclude with a post-panel survey. So just to get us started off, for those M1 and M2s that don't really know how the match works, you first at the beginning of your M4 school year will apply to programs. You can apply to whatever specialties you want, and then those programs will go through a selection period where they choose whether or not they want to interview you. You will then decide whether or not you want to complete an interview with them. You will complete the interview, and then you are able to rank those programs on what you call a rank list. And those programs in turn will also rank you on their list. And that way, hopefully you can match successfully. The greater number of programs you rank increases your odds of successfully matching. So some quick 2023 match statistics. There was roughly 202 applicants at the beginning of the match process that applied to a vascular surgery program. However, only 159 total applicants ranked a vascular surgery program at the end of their match season on the rank list. There was 93 total spots and one went unfilled. And of the 17 individuals who were DO seniors who placed a vascular surgery program on their rank list, 4 of them matched. And then for MD seniors, 92 of them ranked a vascular program, at least one, and 75 of them matched. And then this is just a pie chart. Oh, you're totally fine. Just a pie chart to show kind of the significant difference in the number of DO applicants and those who went matched. For charting outcomes, the number of contiguous ranks, the mean number for a DO is 11. And so contiguous ranks just means that you had 11 ranks in a specific specialty. So 11 ranks in vascular surgery meant that you were more likely to match versus 4.5 meant you were you're unlikely to match. And then most matched and unmatched DO applicants decided to rank at least 2 different specialties on the rank list. And this is just a quick probability. This is for M3s and soon to be M3s as well. So the way that this works is you have a greater probability of ranking or the greater probability of matching if you rank more programs within vascular surgery. So although 11 is the mean, most people look at the 90th percentile, and that's roughly 12 to 13. And then 100th percentile will be like 16 to 17. And then just some quick board scores. For match, actually, if you have a lesser board score for COMLEX, you're more likely to match than a higher one. The only one that was significantly mattered and had a higher step 1, that doesn't matter anymore, it's pass fail. And so step 2, if you had a higher step 2 score, you actually were less likely to match than if you had a lower step 2 score. So vascular surgery doesn't focus as much on step 2 scores. However, you still have to have a high score in order to pass your residency boards. So they still want to make sure that you're competent in test taking and knowledge. And this is just a couple of miscellaneous things. So for experiences, most that went matched had at least 5 research experiences, abstracts, publications, presentations, the mean was 16. And for work experiences, if you had less work experiences and less volunteer experiences, you were more likely to match. And so now I'll pass it off to Nabiha, who's going to introduce our first panelist.
Hi, my name is Nabiha. I'm a third-year medical student at Loyola University, Chicago. I'm going to be introducing Dr. Parikh. Dr. Parikh completed her bachelor's and master's degrees at the University of Buffalo, after which she went to the Edward Via College of Osteopathic Medicine, and then she completed her general surgery residency at Novant Health, New Hanover Regional Medical Center in Wilmington, North Carolina, and her vascular surgery fellowship at Atrium Health Carolinas Medical Center in Charlotte, North Carolina. She is now the assistant professor of vascular and endovascular surgery at the University of South Florida. She practices vascular surgery at Tampa General Hospital with a broad clinical practice, including peripheral vascular disease, aortic pathology, carotid disease, and dialysis access. She serves as the Tampa General Hospital site coordinator for the USF Vascular Surgery Residency and Fellowship Program. She is the Associate Clerkship Director for the third-year Core Surgery Clerkship, and she is involved in clinical research with a focus on utilizing machine learning techniques to perform predictive analytics in surgical patient populations. We really thank Dr. Parikh for being here today. And Dr. Parikh, would you like to share some words with us?
Hi, Nabiha. Thank you so much for hosting, and we're happy to answer any questions that anybody has. And I'm sure everyone's going to do great with their future careers. We're excited to be here to help you in any way.
Thank you. Now I'll pass it off to Zachary.
Hi, everybody. My name is Zach Williams. I'm a second-year medical student at Upstate Medical University, and I will be introducing Dr. Timothy Chilton. Dr. Chilton is the chief resident in the St. Louis University Integrated Vascular Residency Program. He's originally from Colorado and moved briefly to Omaha for his undergraduate before returning to complete his medical education at RVU. He was initially drawn to surgery through his anatomy lab experiences and his experiences in trauma surgery. Not realizing that it was its own specialty, he fully planned to apply to general surgery as an M1 and M2, but as an M3, he was given the opportunity to complete his subspecialty exposure with the local vascular group and was immediately drawn in. While both his open and endovascular interventional modalities pique his interests, he's particularly interested in vascular trauma and hybrid procedures. Outside of medicine, he loves staying active, and he spends a great deal of time in the gym or outside. He and his partner also have 3 dogs, which keep them very busy. So, Dr. Chilton, thank you for being here. And would you like to share some words with us before we start?
Of course, yeah. Thanks, Zach. I appreciate the introduction. I'm Tim. No need for formalities with me on anything. That pretty much sums it up. I was very much thinking I was going to do trauma surgery, mostly because I loved vascular trauma and I liked seeing dissections and ruptures come into the ER. And when I was first presented with my rotation to do vascular surgery, I thought it was going to be all vein work, and I was a little bit bummed out. My first day ever on service was an open AAA in the ER, and I thought, oh, yep, this is it right here. Love it. And I've been chasing that ever since. Currently, I'm a PGY5 applying for my first attending jobs. I am a DO, obviously, and then also my senior fellow, who's my co-chief this year, is also a DO, so we have kind of that going for our program right now. It is very infrequent to see DO residents, and I get very excited to see everyone apply into the integrated program. So I want to thank everyone for taking the time to come out and meet with us today.
Thank you for that, Dr. Chilton. We appreciate it. And now I'd like to pass things off to Jose, who will introduce our last panelist.
Good evening, everyone there. My name is Jose Chacon, currently in Florida, the American University of Integrated Science in Barbados. And I'm here to present back information for, for Dr. Tony Nguyen. And Tony Nguyen is a, let's see, he's a third-year resident, vascular surgery resident at the University of South Florida. He currently, let's see now. Forgive me, I apologize there.
Hey, Jose, just for the sake of time, I'm going to go ahead and move us forward if that's all right. So Dr. Nguyen is a third-year vascular surgery resident. He's at USF, University of South Florida. While attending medical school at the University of Incarnate Word in San Antonio, Texas, he had an interest in vascular surgery, which was sparked due to the local vascular disparities within Southside San Antonio. He found mentorship with doctors Lisa Ochoa and Matthew Seidman, vascular surgeons that are in the local area. And with their support, he was able to present several papers in both the regional and national conferences. He received the Patients Institute Physician in Training Outstanding Professionalism Award and second place in the TOMA student resident poster competition during his M4 years and matched at USF. He currently is in his research year and has an interest in clinical outcomes research in an effort to improve patient care and a particular focus on racial and gender disparities in healthcare. He also has a dog named Moji, and she's an angel. Thank you, Dr. Nguyen, for joining us today. If you could just share a few words with us.
Hey, all. Thank you for the introduction, Natalie. My name's Tony, and like she said, I'm from USF with Dr. Parikh. Not to flex on Tim, but we have also a fellow and a resident and an attending, so there's that. Happy to be here tonight, and looking forward to any questions that y'all have to help you in advancing your careers.
Thank you so much, Dr. Nguyen. Now I'm going to go ahead and move on to the next section. So we have assigned each of the panelists some questions, and all panelists are able to answer the questions. We'd just like to go ahead and allow the panelists assigned to the questions to answer first, if that's all right. So for question 1, this is for panelists Dr. Shilton and Dr. Parikh. It is, how do I approach finding a mentor when I have no home vascular program?
I think this one can be a little bit challenging, especially since so many DO programs don't have a home hospital to come from. There's a couple of resources that you can utilize that do help. Fortunately, if you're familiar with any of the surgeons in the area, sometimes you can just ask them. But SVS actually has a very good mentorship program and setup where you can reach out through their network, and they will connect you to other registered vascular surgeons in the area. I've talked to a number of medical students, both DO and MD, who don't have a home vascular program, and that has been one of their primary resources for getting not only rotational experience, but also exposure into research and some of the academic productivity that helps them shine out on their residency applications is through that database.
Yeah, Tim, I think that's great advice. I think what also can help is, if you're able to, doing AIs at other institutions and creating connections that way. That way you can kind of build personal relationships with some of the attendings and residents. A lot of our acting interns have continued to be involved with research with our groups, even after they've completed their 4 weeks with us. And so I do think that's a great way to meet people, get to know the programs, have the programs get to know you. And be exposed to maybe some things that you're not seeing in the rotations that you're doing at your home institution.
And that's a good thing too. The sub-Is, especially for the M3s, kind of considering what you're going to go through. If you can find out early on, especially what programs are going to have available sub-Is to get into, you're going to have a lot more success. I know when I applied, not only was I the first person to really apply to integrated vascular for my program, but I was one of the first to even consider auditioning for some of those rotations. It was really hard for me to get out there. DO residents and students just traditionally haven't gone into a surgical field. And so even talking to your advisor early on in your M3 year, even M2, before you start to get to that end of M3, early M4 year, when you're going to look to even find rotations to go to, is going to be beneficial because they're going to be a key asset into pointing you in the direction that maybe some previous students have found success.
Just to add, I also didn't have a vascular surgery program. I was a part of the inaugural class, so we didn't have any vascular surgeons part of our institution, let alone surgeons. And so in order to get exposure, once I found out what vascular surgery was, in order to actually shadow a vascular surgeon, I just Googled San Antonio vascular surgeon and just started calling people. Luckily, the people that I called were nice, but the worst they could say to me was, "Oh no, thank you. We don't want a medical student shadowing us." But it helped me find the mentors that I, have to this day. And so, if you can't get connected with the SVS, if you don't have a home program or vascular surgeons that you are associated with or your school's associated with, don't be afraid to call and see if they're even willing to host you.
I completely agree, Tony. I think the worst that can happen is people can say no. And the best that can happen is people say yes, and it ends up being a great opportunity for you to learn and grow and make some connections.
Thank you to all of the panelists for answering that question very thoroughly. We'll go ahead and move on to the next question if Nabiha.
So our question is for Dr. Nguyen and Dr. Chilton, and the question is, how can I make myself a competitive applicant as a DO applying to a surgical subspecialty like vascular surgery?
This one is hard. It's not unique to just DO students for this one. It's going to be kind of around the board, but as a DO student, you're just going to be inherently disadvantaged by those two letters. So trying to do things that would be equivalent at an MD program are to be beneficial. And I know this leads into some other questions that are going to come up later, but I strongly advocate for taking and doing well on your USMLE exams. I cannot tell you how often we have interviewees come up who just get screened out right away because they've only taken Comlex, or they've taken Comlex and done really, really well, but they've clearly blown off step two. I mean, step one, back when we had scores as well, you could see it, but that was a big one. And then doing very well in your core rotations is always going to do well for you. People who, can interview well, can look great on paper, but if you're in the bottom quartile for your, clinical rotations, it's just not going to do well for you. I know right now is even current interview season, and without saying names or things like that, I can tell you that being on this side of it for the last 4 years, that every time someone comes through and they have a red flag, like failing a clerkship or even just performing consistently poorly on preclinical academics and then clinical rotations, it's going to stand out. And it even comes across in your MSPE and your dean's letter. So taking those seriously, even if it's family medicine, psych, OB-GYN, structures that you don't want to be involved with, just knocking those out of the park and just being an all-around well-performing med student is going to do good things for you.
I agree. I think doing as well as you can on step two and taking step one and passing is a boon to your application. You want to make it as easy as possible for program directors when reviewing your application. And if you make an 800 on Comlex, I challenge program directors to figure out what the equivalent of that is in step one and two. And so just making apples to apples comparison is the best way about it. I agree with Tim. Grades and honors, making sure that you kill every rotation. Other things to make you competitive. Natalie went over the match data. Doing research in any capacity. Vascular research is obviously better if you're applying to vascular. Any research is better than no research. And then having extremely strong letters of recommendation, which goes back to the first question. If you establish a mentorship early on and work with your vascular surgeon and develop a relationship, and they can depend on you and you prove yourself and they write you a stellar letter of recommendation, it goes a long way. And then, just like Natalie mentioned, the converse to this question is what doesn't help as much. Collecting leadership positions on like every organization on campus, and then volunteering. It helps, but don't do it in order to strengthen your application. Focus on the opportunities that you like truly care about in those arenas.
I want to kind of add on to that last point there. It's not just that you have things on your application either. be able to talk about them when it comes up to interview sessions, because there's so many students who do so many things, and this person did well in surgery, or they were the secretary of the local surgery club, or whatever have you. That doesn't matter. But if you had a project or a research thing that you were really proud of, or even a non-medical thing that meant a lot to you that you could really discuss and leave an impression on people, that's going to do good things for you too. People all the time will say, I did this research project, and you'll ask them, oh, what was that about? What did you do? And they kind of give you a slate or a wall, nothing they can talk about. You can tell that it wasn't that significant of an experience for them, and it actually ends up doing more harm to your application than good to have excess numbers of subpar data. If you have a handful of things that are really, really impressive, it's going to always look better than someone who's got, 100 things that are just going to be meh.
Thank you for your insight. Now I'll pass it off to Omar.
Thank you, Nabia, and thank you to the panelists. So my name is Omar. I'm a second-year medical student at the University of Miami. This question was kind of answered in the last one, but regardless, it's directed towards Dr. Parikh and Dr. Chilton. So with level 1 and step 1 being pass-fail, do you believe there's any merit in still sitting for step 1?
I very much do. I've said that, but even on applications now, and on some of the surgical application subreddits, I say this too. Please sit for step 1 and pass it. Even if it's something that you don't need technically, there are programs who will just filter by step 1 status, and even if you've done great on level 1, for example, they might just see no step score and just wipe your application. It also is a comparison between your MD colleagues who are going to just outnumber you both in overall numbers of applicants and a lot of times just frank experiences based on the accessibility that they're going to have. And so just having one more data point to say that there's an equivalence there is never going to be a bad thing.
Yeah, I definitely agree. We do look at the step 1 pass fail and the step 2 score. So if you're going to do it, I agree, do it well, and I would take the step 2 so that your scores are available for application time. As long as you're confident, you're going to do well. People don't know how to evaluate complex scores.
Okay, thank you both so much. I'm gonna pass it off to Jose now, who's gonna ask the next question.
Thank you very much there, Omar. My name is Jose Chacon. I'm currently employed at the American University of Integrated Science in Barbados. I want to apologize for the earlier technical issue we had earlier there, but we seem to have resolved that. For this next question, I'd like to turn over this question to both Drs. Parikh and Dr. Wang. The question is, what are your thoughts on a strong letter of recommendation from a non-surgery physician?
I think if you want to be a surgeon, then you should prove that you've worked with surgeons and that they can speak to your knowledge, your skill set, your character. Now, it doesn't need to be a vascular surgeon. Granted, the vascular surgery community is very small, and so everybody does know everyone. And so that is helpful if you can get a strong letter from a vascular surgeon. But I do think that if you're applying for surgery, your letter should be from surgeons.
I agree with Dr. Parikh. My general advice for this is that a vascular surgeon is better than any surgeon, which is better than a non-surgeon, which is better than non-medicine. And so if you have 2 strong letters of recommendation from 2 vascular surgeons in the academic community, and you want your research PI to write a letter, sure. If a medicine physician that you've worked with for years writes you like killer letter of recommendation, sure. But the bottom line is make sure that it's an exception, that if you have a non-surgeon writing a letter, make sure that it is in addition to strong surgical letters of recommendation, because if you want to join the specialty, the best way to convince vascular surgeons that you're a good fit is having a vascular surgeon write on your behalf that you are a good fit. And then this harkens back to a previous question that was asked, but Make sure that you do well in all of your rotations, because stronger recommendations comes in various ways. One of the rotations that I had was internal medicine, and my evaluation was finally a vascular surgeon who knows medicine. And so having that recommendation and applying with it, like having it be a part of my application, shows that like I've been dedicated since the third year and that I can prove myself in other rotations.
Okay, thank you very much, both Dr. Parikh and Dr. Nguyen, for your responses there. Now pass it over to Zachary.
Thank you, Jose. This question is for Drs. Chilton and Nguyen. And the question is, what are some struggles that you anticipate a DO applicant today having, and what are some ways that they would be able to proactively deal with it?
This one goes back to some of the things we've talked about. I mean, having the DO acronym behind your name is automatically going to draw a little bit of attention to yourself. I know that during my interviews, all, if not just my vascular ones, but I do apply to all my general surgery ones, I believe also asked it, well, you know, what does it mean to you to be a DO? Are you going to still employ some of those DO teachings, things that you're a part of? They were all curious about it. But the other side of that was people still hold on to this inherent bias that DOs are somehow still less than MDs in terms of their capabilities as a resident, a surgeon going forward. And they are going to grill you on this. And it's not always friendly grilling. I kind of joke about it, but I had it at one of my interviews, one of my very first ones when I was early M4. I sat down in someone's office for an interview and they were 20 minutes late, didn't really look at my application. The first thing he walks in, opens it up and goes, huh, I guess I see you're a DO, and put it right back down and goes, I just don't get it. Were you just a bad college student? And that was the first thing he said right out of the bat. And so dealing with those kinds of comments was not a one-off. I had it 4 or 5 other interviews where someone brings it up. And so you have to have a prepared answer to say, why did you go to a DO program? It doesn't have to be a rehearsed, polished thing, but you should have a good explanation as to not only why that was the route you went, but how also that not only makes you a good and well-rounded candidate for what you're about to do, but also why it's going to make you stand out above your peers going forward into that rank list. So just have a way to answer that question when it comes up, because it will come up multiple times.
To kind of piggyback off of Tim's answer, it's okay to say, at least I thought it was, to say that, yeah, I wasn't that strong of a college student. Like I worked, 15 jobs during college to pay for tuition, and that's why I didn't do great. But I saw the light when I was in my osteopathic medical school, and I crushed it. And I have the board scores to back it up. I have all of the extracurriculars to back it up. So it is okay to admit, I think it's okay, if it's the honest answer, to admit why. If you wanted specifically to become a DO, then say that reason. Or if you truly believe in the holistic medicine, say that reason. But just be honest with that answer. To answer the question specifically, though, the struggles that I think a DO applicant today would have, I'm not sure if the MS4s now or MS3s, I don't know where the cutoff is, but if step one is no longer graded for your class, you will have an immense amount of difficulty. I think step one being pass fail was a huge detriment to the DO community, just because that was the great leveler. You could prove like, I can do as well as my MD counter. I can do better than my MD counterpart. But now you have to wait until step two in order to prove yourself. And what happens if you bomb it? Like you're so far away, like you can't shore up your. It's a little late in the game if you bomb step two to come up with a backup plan. But since step one and step two is pass fail, you can go to other things like research or building a relationship with a mentor. And then obviously the thing that most DOs have, like today and before, was that we don't have vascular surgery residencies or fellowships at our institute, let alone hospitals at our institutions.
Thank you both very much for those answers. I appreciate it. I'll now pass it off to Natalie, who will ask the next question.
Thank you, Zach. For our next question, it's going to be for Dr. Shilton and Dr. Nguyen. And, oh, sorry, no, incorrect. It's for Dr. Parikh and Dr. Nguyen. And it's, as a DO, should I dual apply? And what are your perspectives on pivoting and applying to both preliminary and categorical spots? And this is regard to things like general surgery.
This one is also tough, and I dual applied, so I will be very honest about that. I did not dual apply for any prelim spots though, so I don't recommend this just for DOs. I recommend this for anyone. If you are serious about vascular surgery, you know that's what you want to do, and your academics are excellent where you're going to get enough interviews right out of the bat, I think it's okay to apply just to one. But like I'd said before, I was the only person in my program who'd ever applied to vascular surgery. And as a DO matching in any surgical field, it is harder, even with good scores, than it is for an MD program or an MD student graduating. So I did dual apply. For my vascular application, I had entirely different personal statements. It was similar to my general surgery one, but it was different. And I did not apply to any of the same programs for general surgery as I did for vascular surgery, just for the fear that program directors might talk to each other about their applicants. You don't want to seem like you're not committed to one or the other. In terms of where I applied general surgery, I applied really just locally, so I could be closer to home if that's the route that I went. But vascular surgery, I applied to almost every program. Once I had enough vascular interviews where I knew I'd be able to have a set number in my rank, I stopped accepting general surgery interview requests. But in terms of prelim versus categorical, that is a very hard question to answer, and I'll give maybe a mixed perspective here. If you are applying to a prelim spot, it guarantees in almost every setting that you're going to be reapplying for residency again in a calendar year. That can be very stressful for a lot of people, and some people it ends up with them transitioning out of surgery altogether. If you apply to a categorical spot, odds are you're going to finish your surgical residency. Now, you can still do fellowship at the end of that and get a well-rounded surgical perspective and certainly be more competitive into fellowship than you were initially into residency. And for some people, that's a really, really good thing. It does add a little bit of time to you, but it means that if you wanted to do vascular surgery from the get-go, you're going to do that. Versus prelim, it gets hard. And as much as there shouldn't be this level of bias, there is a level of bias in people who are prelims coming to apply again for surgical fields when there are graduating M3s, M4s who might have better scores right at the get-go and might be easier to train or mold. Whether that's fair or not is a different discussion, but they do seem to have a harder time as a prelim reapplicant through the match cycle.
Yeah, I only applied to general surgery programs, and so I can't really speak to the applying to both. I think there's definitely benefits to both tracks, to the integrated and the traditional pathway. That being said, I don't think that if you want to be a vascular surgeon, I don't think anybody would look down on you for applying to both, even if you did it at the same programs. I've seen all students, MD and DO students, that are dual applying for general and vascular surgery because they just want to increase their odds of becoming a surgeon. And the traditional path is still, a respectable path to getting to your end goal. Or you may end up deciding that you like something else more, and you may end up pivoting, and that's completely fine too. I would not apply to the same programs for categorical and preliminary because I think that you're kind of putting yourself into a box, and it's making it seem like you are not confident in your application. So if you were going to apply to preliminary positions, I would not do that at the same places that you're applying for categorical positions. But I do agree with what Tim said, that there are many programs that have multiple preliminary spots, and they're not helping those people find categorical positions. So if you are going to, take a preliminary spot either through the match or through, the whatever the new version of the scramble is called, then I would, make sure that you're going to a place that's going to support you in whatever the next step of your career is.
I want to stress something that Tim said. First, to answer the question, yes, you should dual apply as a DO. I would think of both training paradigms as a means to an end. If you're applying to general surgery as well as vascular, make sure you have two separate applications, different set of letters, and make sure that you stress to the letter writers that I need you to write both a vascular letter and a general surgery letter. If you're having a vascular surgeon write you a letter for your general surgery application, I would prep for the interviews the same way that you do for your vascular interviews. So if they ask why general surgery, if you have 1,000 vascular surgery publications, just do some self-reflection and make sure that you know why you're applying general surgery with an ultimate goal of vascular surgery. There's not enough open abdominal experience as a vascular surgeon in a lot of the training programs out there. And so I want a general surgery experience before my vascular surgery training. Valid answer. Whatever it is, just make sure that you're prepared for the interview. Regarding preliminary spots, I'm going to take a different approach in answering this question. I think that it takes a lot of self-reflection to evaluate the strength of your application and recognize whether you are going to match or not. It is easier. It is difficult to go into vascular or general surgery in a preliminary spot. It is even more so if you don't match. It is easier to be a surgeon if you're a doctor first. And so if you're in any way, shape, or form at risk for not matching, look at preliminary positions. If you're unsure about your application, look at preliminary positions and look to the programs that historically have matched their preliminary general surgeons. Because there are some pathologic programs out there that will match you and they will tell you to your face, you're not staying on. And so those are the programs that you want to steer clear of, but make sure you don't scramble. It is a stressful position. And so just make sure you stay out of it. And if it's a prelim spot that you end up matching, it sucks, but it's better than not being a doctor for a whole year. That's harder to square away than just being a prelim.
Thank you all for that insight. Now I'm going to go ahead and pass it off to Nabiha for the next question.
Sorry. Okay, this next question is for Dr. Chilton and Dr. Wen, and it's what are ways I can continue to strengthen my application if I do not match vascular surgery on my first attempt?
This is going to be a lot of the same answers as last time, but it's going to be having strong letters of recommendation from a vascular surgery or a vascular surgeon in general. If you can get a letter on behalf, or I guess from the program director or the head of the department, that's going to sing stronger than a community vascular surgeon. But definitely at that point, they're kind of expecting that you should be getting letters of recommendation from vascular surgeons, with the exception of that rule being that you should be getting a good letter of recommendation from your current program director as well. If you are a general surgery prelim, for example, and you are applying into vascular surgery as a second round to the match, getting a good letter from both vascular surgeons and from your PD are going to look very good for you, on top of doing well in your in-service exams to show that, yes, you can apply yourself and study and perform well academically. If we're talking about someone who's then going to go through and apply to fellowship, that's a very different conversation. But if it's truly a prelim situation into Gen Surge, good letter from your PD, strong in-service training scores, which might or may not be down by the time you're going through your application, because that's usually in December to January-ish, and you're probably already interviewing. And then vascular surgeons in the hospital, specifically PDs or department chairs.
To add on, I think during the year that you're not in a vascular surgery residency, doing research is also extremely helpful. One, like vascular surgery specific research, it lengthens your CV, but you also go on to present these projects at conferences, and you just rub shoulders with other vascular surgeons. And so helping get your name out there in any way at interviews, leveraging interviews during this time, it helps. So just getting your name out there. Let me see. And then fellowship is completely different. This is, I'm assuming this question is just gen surge or prelim into vascular surgery.
Yeah, I think that was the intention.
No problem.
Thank you both. Now I'll pass it off to Jose.
Thank you there, Nabina. For this next question, this will be for all the panel members. And if you want to, excuse me, if Dr. Chilton can start with it. And the question is, what is one piece of advice you wish someone would that told you going through this process?
Am I starting off or?
You can go ahead, Tony. It's up to you. I got to think about this one a little bit. I wrote an answer down, but I'm not sure it's good enough.
So this might be just a personal answer. Put some effort into your general surgery application. Everyone should dual apply. That's a DO. If not DO and MD, but everyone should dual apply, and you should put effort into your general surgery application. I did, but not to the same extent. Or I think I told my mentor to write a general surgery letter, and I think vascular might have ended up on it, something. But I only got 2 general surgery interviews. I received like 20 plus vascular interviews, but I was like, what's going on? Why is my application not good enough? And for a brand new DO program, I was extremely worried that I wouldn't match. So I would put some effort into your backup plan, again, just because it is easier to match into a vascular surgery residency than it is as a prelim or as a general surgeon than it is taking a year off. But I feel like that's a little more because of the faults that I had.
I don't essentially faults though. I think it's beneficial to put a lot of effort into your backup plan, because this is not something that's like I spent a week planning this event. This is something that you spent 4 years of undergrad plus 4 years of medical school getting to. And it is silly with the amount of debt and time you've committed to this to not have a well thought out, in case it doesn't work, arrangement put into place. So I think that is a very well thought out piece of advice, is to have your backup plan put together. I'd say that I had a lot of vascular surgery interviews, but not that many general surgery ones. And my step 1 and my level 1 scores were both competitive. I had a good GPA, but even then, especially a general surgery, unless you're applying to a lot of DO friendly, traditionally friendly programs, it's going to be harder. And I don't know if that has changed now compared to when I applied, because I applied the year after they actually had the merger. So when I applied, there were still some programs that were DO only, which has obviously since changed. And even with the interview cycle, everything we did was in person. If I would give one piece of advice, though, to this, we mentioned it a little bit earlier, it's that get a chance to get early exposure to AIs or sub-Is or whatever you want to call them, but see how other groups run vascular. If you are exposed only to your home program, or if your home mentors approach to things, you're going to be kind of at a disadvantage when you start to show up to interviews and people ask you about your experience, or even about getting letters of recommendation, or just a broader ability to explain to your interviewers what you're doing and why you want to do this. That is something I did not get on early enough, and I really should have. Overall, it didn't end up causing me too much difficulty. I still matched, but it definitely was something that I was very self-conscious of, talking to my peers on the interview trail who'd said they'd done interviews at sub-Is all over the place. And I was like, oh, I didn't do that. And I didn't realize it until after it was October, September-esque. That's kind of late to get in there. It's not impossible, but if you can get sub-Is in June, July, August, and get letters of recommendation from different programs in their PDs or their department chairs, you're going to look a lot more stellar on that application, and people are going to notice, that ability to have one vascular surgeon who's got a strong reputation in the community be your sponsor carries a lot of weight.
Yeah, I completely agree. You know, we get like a lot of letters from similar vascular surgery attendings from similar institutions. And I do agree that, you know, having a strong letter from those people who you have like worked with personally, think highly of you, you've shown them that you have a strong knowledge base, that you have a good skill set, you have a good work ethic, that goes very far. Somebody else saying that about you. So if you're going to go do a sub-I, treat everyone with kindness and respect, go in prepared, be a hard worker, be present, meet everybody, let them know what your intentions are. You know, even the staff that you're working with, everybody talks. These are all small places. Even if it's 1,000-bed hospital, they're small places. So everybody talks. Be kind and work well with everyone that you see and work with. My one piece of advice that I would give to people is be confident in who and what you are. You know, if it's not the DOMD thing, it's going to be something else that people are going to try to bring you down about. If you feel confident that this is what you're supposed to do with your life, present yourself that way, you know, and I think that where there's a will, there is a way in figuring out how to get there, even if it's not a traditional path. And so be confident in the work that you've done up until now, and show that, you know, in your application, in your interviews, as you meet people at conferences, because that does shine through. People can see that confidence, and people are drawn to it.
Another piece of advice that I have, I wrote it down. This is something that I did during my third year specifically, is it helped me do well during my rotations, was compare vascular surgery to every rotation that you're on, and think to yourself, is this and everything this specialty has to offer something I'm willing to give up in order to pursue vascular surgery? And give it a fair shake. Do the best you can during the rotation, because if you ultimately decide, you know what, vascular surgery is still for me despite this psych or pediatrics rotation, it's the last time you're going to see that. And so do as well as you can on the rotation, and have that mentality in mind. It's like, this is the last time I'm going to see this. And it works twofold. One, you work harder and it makes for a better evaluation. And two, it's a modality for self-reflection. It's like, maybe not. This is an aspect of medicine that I truly enjoy, and I'm not sure if I want to give it up completely. So during your third year, really try hard to like assess, is this something that I want to do? And if it is, it just reinforces vascular surgery, and that it's something that you should pursue.
Yeah, I completely agree with that. I think sometimes people
Dr. Pariki cut out. I think what she was going to say is she completely agrees with me, and I'm the best resident that she's ever seen.
It is a good point, though. I mean, I tell this to my students now when they're coming through, and I'm at an MD program, but I always tell them that even if you find something you like, take everything with a grain of salt and just try to expose yourself to all the different facets of medicine. You know, I, for example, thought for a little bit maybe I wanted to do OB because, God, I love delivering babies. I think it is so much fun. The rest of OB was my nightmare, and I hated every second of it. Even like all the prenatal visits just drove me up a wall. But delivering babies, that 1 second of OB was cool. And there's no way I could have gone through an entire residence doing that. And students who come through and say, yeah, man, I think that open aortas are the coolest thing in the world, but you hate PAD, or you hate dialysis access, or all these other things that, you know, maintain a work practice, you're going to be unhappy. And so students coming through who might have a limited experience in community vascular surgery, and someone who's doing carotids and, you know, open bypass, but has never seen dialysis access, has never seen, you know, complex endo, they might hate the endo suite. And I think as a vascular surgeon going forward and through training, that's going to make, you know, 30 to 70%, depending where you're at of your training, really uncomfortable. And you have to be aware of those things before you start.
Thank you very much, Sean, both for your responses there. Now I'm going to turn over to Zachary.
All right, thank you again, Jose. The last question for the night is, how can I become more involved in vascular surgery without a vascular surgery interest group at my school? This question is supposed to be for all the panelists, but Dr. Chilton, if you would like to go first, we'd really appreciate it.
This is also hard, and it kind of comes down to the same thing we talked about with SVS, but getting involved without a vascular interest is going to be a disadvantage across the board. If you know that's what you want, it's what you like to do, Tony, props to you for just cold calling people. That takes a lot of just balls to go ahead and do that. I tried doing that for jobs, and even now I get nervous doing that kind of reach out. But you're going to have people who are going to be at your institution, or you should anyway, who are responsible for connecting you to the community. There's going to be someone who's a surgical coordinator or a surgical, residency application director who can point you in a direction of a surgeon in the area that might be helpful. You might have local community general surgeons who might know somebody. You have the SVS, and you have, cold calling people. But I also probably imagine if you have the access to this, you're probably not the only student in your group who might find it interesting to do some kind of vascular rotation, and just talking amongst yourselves and saying, hey, we like this, and bringing it to a school as a rotation option. They might be able to just plug you all in with someone in the community.
Yeah, and I would look into the societies too. The societies have yearly meetings, and they have sections in those meetings specifically for medical students, specifically for residents and fellows. And so they want people to get involved. I know like the Society for Clinical Vascular Surgery is looking to, try to bring more medical students in and get them more involved, both for like the conference and, throughout the year. And so, I would be proactive about researching those kinds of things, especially if you don't have a home institution that's going to allow you to, create like a vascular surgery interest group. Otherwise, I would get involved in the surgery interest group overall. And, you can try to connect with vascular surgeons in the area and be able to bring some of those skills to the group. Vascular surgery is very much still a part of general surgery and general surgery training. And so I think that would be something unique that you could bring to the group, and something that you could talk about and would be seen highly of in interviews moving forward.
I just want to thank all of our panelists today for really, just excellent responses to all of these questions. And I also want to take an opportunity to thank all of y'all for joining us today. This is our post-event survey. If you could just whiz your phone over the QR code. And then these are some resources for y'all. I think that they pretty much said the same stuff. And if we could just move on to the next slide really quick. Kind of to add on to that last question, we really were, again, VESS VSIG. We are a bunch of students from all over. If you're interested in joining us, you can join a VSIG just by joining VESS VSIG. So just email us at vessvsig@gmail.com. And again, this is the same QR code for the post-panel survey. So also, I believe Tony has placed his email address in the chat. So if y'all guys want to, reach out to him, he's happy to answer any questions for y'all. Thank you all so much again. I hope you all take care.